It's the 12th of January, 2018. This is the RheumNow Week in Review. I'm Dr. Jack Cush, Executive Editor of RheumNow.com. This week in the news, what happens when our patients go to surgery? Calcium and vitamin D may not be all that it's cranked up to be. And yes, you actually can predict immune-related adverse events in patients receiving checkpoint inhibitors. A lot of that's in the news lately. So top of the news is an interesting story about what happens when orthopedists sort of double book and try to do surgery. I don't know if you're aware of this practice. I wasn't, but this study from JAMA talked about hip replacement surgeries being done on patients with hip osteoarthritis, and the hazards of doing overlapping surgeries. A practice wherein the supervising or head physician, head surgeon, does two or more simultaneous surgeries and supervises the surgeries done by other patients. The outcomes here were complication rates, and in fact, they showed significantly higher complication rates, 90% more complications when this practice went into effect. And those are complications all observed within the first year. Obviously, not a good practice to double book and do overlapping surgeries. Dan Solomon and colleagues looked at the cost of care, an updated cost of care analysis. This is a meta-analysis of many, many papers. It turns out that there were very few that qualified, 12 out of the hundreds they looked at, and only a third of these had what they called good quality data. They showed that the total medical cost of caring for someone with rheumatoid arthritis was $12,509 for all RA patients. It was actually higher if you're on a biologic DMARD, in fact, 3 times higher, 36,000, and that RA specific costs were only 3,700 for all RA patients, but up to $20,000 for biologic DMARDs. Again, the cost of care in RA has gone up over time. The cost of care has been supplanted uh, by the biologics. It used to be the cost of care was driven by hospitalizations and surgery. Now it's the cost of the biologics, the cost of the drug therapy. A new study looked at familial Mediterranean fever patients from an Israeli population, and just did a population analysis of 8,534 patients. They saw that the risk of developing cancer was in fact lower amongst these FMF patients. The standardized incidence ratio was 34% lower compared to the general population, which is kind of novel because, as you know, inflammation drives cancer risk. Almost all the diseases we take care of have some kind of cancer risk, and it's usually not from the drugs, it's usually from the therapy, it's usually from the disease itself, the inflammation itself. And these studies suggest, well, it may be different in disorders of innate immunity, such as FMF and autoinflammatory syndrome, compared to disorders of adaptive immunity, which is what you see with lupus, rheumatoid arthritis, etc. So the question is it a difference between involvement of the inflammasome or adaptive immunity? One other explanation for this data could be the effect of therapy. And they did not look at that. They were not able to look at that in this particular study. But let's just say these FMF patients were effectively treated with effective therapies, many of which could have involved IL-1 inhibition or drugs to control inflammasome activity. And we do know from a recent study, the study of canakinumab, where it was used to treat patients with heart failure, it was showed that it did reduce heart failure and cardiac events. It was also shown that patients on canakinumab, the IL-1 inhibitor, in heart at-risk cardiac patients only, they had a lower risk of cancer, especially lung cancer, which has now led to such therapy being tried in cancer trials. So could it be that this lower cancer risk in these FMF patients was because they were being treated? Again, I think we need more data on this, but I think it's a very interesting finding. Recently announced data from Horizon about its product pegloticase shows that up until recently they were bringing in about over $400 million in sales, and they project in 2018 to do 750 million or above. This parallels the number of patients who have been treated with this drug has increased from 50,000 to nearly 100,000. So again, early on there was a lot of hesitancy about using pegloticase to treat patients with severe refractory gout. I think physicians learning more about this drug, showing that in fact it can be effective therapy. A tidbit, and this is from my own clinic. I use leflunomide just like all of you, but I might use it differently, and that's because of my working on the drug in clinical trials, understanding the biology of the drug. Turns out leflunomide has a very long half-life. It's somewhere between 18 and 20 days. As such, it would be a great drug for not once a day dosing, but once a week dosing. And this is what I in fact do in a majority of patients who are on stable doses of leflunomide. So I will start them on 20 milligrams daily, as all of you, monitoring the same way. But after they achieve a response, which is usually 6 to 12 weeks, and they're on a stable dose, I will switch to once weekly dosing. I will also switch to once weekly dosing if patients are having problems with either GI symptoms or hypertension or hair loss, in which case I will lower the dose and they'll receive 80 milligrams or 100 milligrams or 60 milligrams once a week and see if that will be enough to control them. So when I switch to once a week dosing, I use 20 milligram tablets. I say take 4 or 5 or 6 tablets once a week every Friday. And patients do very well. In switching over from daily dosing to weekly dosing, there is no loss of effect. And you still continue to monitor the patient as you normally would in your clinic and still monitor their labs in the same manner. That's, I think, a helpful way of using the drug leflunomide. A recent study of Swedish construction workers, over 300,000 of them, looked at the incidence of lumbar spinal stenosis surgery. And this is a very large cohort followed for over 31 years. In the end, they found that 1,600 plus patients went on to receive spinal stenosis surgery. And curiously, they find that the rates are highest in those who are heavy smokers. Now, what does that mean? Again, it could be that just heavy smokers is a surrogate for those who have more disease, more comorbidities, less attention to healthcare, maybe less attention to healthcare services. It could also be that this is like a lot of studies what we see where you're dredging for a p-value. You put a large cohort in, you try to find out what's significant, and I often wonder about how real such studies are. It reminds me of all the studies about coffee and the associations of coffee with pancreatic cancer and all kinds of things. Again, it's hard to tell in these post hoc sort of population analyses, especially when it's in claims data. But that's out there. You know, your construction workers should stop smoking so they don't have to have lumbar surgery, I guess would be the take-home message. Gabapentinoid use, as you know, is sort of widespread. A few years ago, it was only about 1%. And now in 2015, it's gone to 3.9% of adults. And that I guess it owes to a lot of these off-label indications for gabapentin for the management of pain and I mean, its primary indication, of course, was for seizures, but it's gone on to be used for pain, for sleep, for migraine headaches, etc. So again, gabapentinoid use is taking over, especially in an era when opioid doses or opioid use is actually declined. So this may be the new substitute. Another study, interesting study from Canada, looks at those exposed to leflunomide during pregnancy. So in the Canadian healthcare databases between 1998 and 2015, they found over 300 or almost 300,000 pregnancies, rheumatoid pregnancies. And amongst those, there were 51 who had received leflunomide within the first trimester of the pregnancy diagnosis. There was another 21 patients who received leflunomide in the second and third trimester. And interestingly, there's no increased risk of spontaneous abortion, malformations, prematurity, or low birth weight. This is a follow-on to the data that was published out of Otis, commissioned originally by Aventis to study the effects of leflunomide on pregnancy. And it took them many years, and I think they only had about 70 different cases, but they also did not show an increased rate of malformations or fetal complications when patients were exposed, the infant was exposed to leflunomide. It still remains a serious risk. Patients should not get pregnant while on leflunomide. On the other hand, those who do, both of these studies would suggest that the outcomes will probably be okay for both the mother and the child. A recent study, as you know, last week on our website, we had a lot of discussion about these new checkpoint inhibitors and what happens with them as far as developing immune-related adverse events. Last week's report featured some discussion and a commentary by Len Calabrese about what happens when you give these checkpoint inhibitors to patients with autoimmune disease. And in fact, 75% of them will develop these immune-related adverse events, arthritis, myositis, hypophysitis, etc. Well, there's an interesting study this week in PNAS that looks at, I'm sorry, this is the Journal of Clinical Investigation, that looks at the ability to predict these autoimmune adverse events when receiving checkpoint inhibitors. And this was done in a small cohort of 39 or so melanoma patients who were receiving either inhibitors of CTLA4 or PD1 or PDL1. And after they did studies before and after the first cycle of therapy, and they showed there were significant declines in B cell numbers and an increase in CD21 low B cells and also plasmablasts. So it's thought that this could be a significant change that is you can monitor and may be able to predict and do something about these potentially harmful adverse events. What they did show was that the early development of these B cell changes were associated with higher rates of grade 3 and grade 4 immune-related adverse events. This all occurred within the first 6 months of receiving either one of those drugs or a combination of those drugs. So it's an interesting development. There's a problem with these patients. Their identification is getting easier, but their treatment still remains hard. A new report from the CDC talks about how good physicians are at counseling their patients on exercise when they have arthritis. In this particular study, they looked at the data from the 2002 and 2014 National Health Interview Survey, NHIS, that involved over 36,000 adults. These are telephone surveys. And what they showed was that 2002, about 50% of patients received guidance from their physician about exercise when they had arthritis. This grew by almost 18% to 61% in 2014. This is still, while that's good growth and a significant improvement, these numbers fall far behind current guidelines and CDC guidelines for exercise counseling. It is estimated that even patients who are maybe more inactive may have even greater a greater loss or deficit in receiving such instruction. The point is that we need to program this into our daily lives. When patients have such findings, we need to counsel them in a sort of predictable manner. The authors recommend a website. They also recommend maybe programming this into the electronic medical record. Another study looked at what happens when early RA patients are studied with regard to adverse events. This comes from the NEO-RACO study. 98 early RA patients were followed over time, and again, these had very early RA. They actually averaged 5.5 adverse events in the course of this one-year study. They had an 8% risk of developing a severe or serious adverse event, and 24% actually of these adverse events led to drug discontinuation. What they really found that was sort of interesting and surprising was that with increasing tertiles of -28 activity, with increasing disease activity, there were higher rates of SAEs, serious adverse events, and AEs, suggesting that, again, it may not be the drugs that are driving risk in many of these patients. It may be comorbidity, it may be disease activity. It's a complicated equation that leads to why someone will have an adverse event and then discontinue the drug, either temporarily or permanently. And lastly, there's a report from JAMA that did a meta-analysis systematic review of 31 randomized clinical trials with over 51,000 participants to look at the influence of oral calcium and/or oral vitamin D supplementation on the risk of hip fracture. And they compared that to those who either received a placebo or received no therapy at all. And they showed that there was no significant risk. In fact, if you compare the risk of hip fracture for those who received vitamin D or calcium, the relative risk is 1.53, and it overlaps from 0.97 to 2.42. Looking at the confidence intervals, that's just for calcium. Vitamin D, it's a little bit lower. So there seems to be a little bit of a trend, but it's not significant. In fact, it's even lower if you look at the combination of vitamin D and calcium as it may influence hip fracture, where the relative risk is only 1.09. And again, this goes between 0 and 1.4. So the bottom line is that the routine use of vitamin D and calcium, especially in elderly people, community populations, doesn't seem in itself to reduce the risk of one of the things we're most concerned about, that being hip fractures and disability from that. That's it for RheumNow, and go to the website. You can actually get the links to these studies and read more about these studies. I'll also encourage you, for those who don't know about it, the RWCS meeting is coming up in Maui. As you know, RWCS is an annual meeting run by Dr. Kavanaugh and George Martin. And it's a wonderful meeting that starts on February the 7th and goes through the 10th. Now, there's a few slots left for those of you who may be interested in going. The faculty every year turns over. We have new grand teachers who we call the kahuna. And I think this year's faculty and the program, you'll find, is really exciting. You can see more about that at r-w-r- it's RWCS with dashes in between, r-w-c-s.com. But that was tough. Anyway, see you next time. Bye.